The Academy is pleased to present today Dr. Donovan, who's an assistant professor of medicine and one of our associate program directors for the internal medicine residency, and spends a lot of her time and energy talking to our residents about how to teach. And one of the things that we spend a fair amount of time trying to address for them is the concept of role modeling. We talk a lot about role modeling, that it's a way that we teach all the time, but we're not necessarily explicit in how we train our trainees to role model. So with that, we asked Anna to talk a little bit for us today about, again, how to take that skill to the next level.
Good morning, everyone. Can everybody hear me? Okay. Thank you for the invitation to speak today and for the introduction. As Missy said, this is something that I started thinking about when we were teaching the interns how to teach, but I actually learned a lot myself about how to be more intentional in my role modeling, and so I'll walk you through a little bit of the method that we recommend for the interns, as well as some of the thinking behind it. I want this to be useful, like every talk, so if there's anything that, feel free to interrupt me if there's anything that comes up that you have questions or confusion about. I'd like to start with this quote, which was published a long time ago in academic medicine. Role modeling remains one crucial area where standards are elusive and where repeated negative learning experiences may adversely impact the development of professionalism in medical students and residents. This was in 2003. The standards were elusive, and based on what's been published since that time, 14 years later, or lack thereof, I don't think that we have a great codified way that we teach role modeling. So I'd like you to just take a minute to think back to teachers and role models that you had in your training, either in medical school or residency. Just pull up a couple figures in your mind. And so what made those people, and you don't have to say it out loud yet, I may ask you to share just to get the morning going, but think about what made those people great role models. Or if you chose somebody not so great, what made them a not so great role model? Does anybody care to share either of those features?
They're actually very supportive.
Okay.
And actually spoke very little.
Okay. So supportive and didn't say a lot of stuff.
They kind of let you speak, and then they would take the things that you had said that were noteworthy, stood out, commendable, and said, that was great, highlighted a few key things that people had done that were really great to sort of magnify the impact for other people, and then just let it alone. Okay,
did everybody hear what Greg said? And I'm probably gonna paraphrase that a little bit just to pick out some key points. So it was short, it was learner-centered and focused, and included some teaching skill to keep learners progressing. Okay, anybody else want to? Yes, Twee.
So along Greg's point, it's somehow more action-oriented. Not so much to sit there and tell you these things, but what they do in their action, whether it's demonstrating a skill set by what they do.
Okay, so it's more action and oriented than maybe theory oriented or concept oriented. Okay, good. Anything? One more person want to share? Okay, good. Thank you for sharing those. Anybody pull up some not so great role models mentally that they wanted to think about why they kind of missed the ball? Okay, so that's not who we remember from medical school, and maybe that's a good thing. So I'm going to talk a little bit about individual characteristics of role models as individuals, talk a little bit about unconscious role modeling, and then I'm going to move into role modeling as an active skill set, talk a little bit about the educational theory behind it, when we can use it, the steps, and then I'm going to go over some homegrown videos practicing those skills that we can talk about, talk a little bit about next step and maybe barriers if we have time. So role models are defined as a person whose behavior, example, or success is or can be emulated by others, especially by younger people. That's sort of the dictionary standard definition. The term was coined by Robert Merton, who was a sociologist in the mid-20th century, and it wasn't really a lay term that people knew until the 1990s. It kind of came up in the business literature in the 70s. It's really been in the last 20 or so years that we've been using this term in a common parlance. In medicine, one of the ways that it was defined, again, 17 years ago in academic medicine, these are individuals admired for their ways of being and acting as professionals. So this one article, that if you're interested, I really liked, and it talks a lot about role modeling, and one of the things they talk about is the characteristics, the positive and negative characteristics of role models, and these are broken down into 3 domains: clinical competency, teaching skills, and personal qualities. So if we go into them, some of these are things that you already mentioned and recognized this morning. The left is positive characteristics, and the right are the corresponding negative characteristics. So in the clinical competency domain, good role models have excellent knowledge and skill, effective communication, and sound clinical reasoning, which is fairly intuitive. In terms of teaching skills, again, if you look down the left, they're aware of their role, they're explicit about what is modeled, they make time for teaching, they show respect for student needs, they provide timely feedback, and they encourage reflection in students, which may have been some of what you were getting at, Greg, about they weren't doing all the talking, they were getting you to talk and pick up what you recognized. And then for the third domain, personal qualities, so again, compassionate and caring, honest and having integrity, enthusiastic for the practice of medicine, effective in their interpersonal skills, committed to excellence, collegial, and demonstrating humor. So if we think a little bit about role models and where they operate in the medical school or even the residency curricula, they operate in all 3 levels of curricula. So if we think about our formal curricula with syllabi and course objectives and what clinical teachers believe they are teaching, role models are operating in that way. And then if we think about informal teaching or informal curricula, there are often unscripted, unplanned teaching and learning encounters. And this is where we can sometimes not be the best role model if we're not conscious of what we're doing. And then the hidden curriculum is more thinking about the organization's culture and institutional structure. So if people get berated for paging a consultant or a specialist, that's a hidden curriculum. If people don't have a culture of respecting their patients and honoring their patients' needs, those are things that are sort of part of the hidden curriculum as well as these other layers of curriculum. So learners are observing all of our actions when they're with us, the good, the bad, and the ugly, and we may not be aware of it or proud of it at some times. And there are actually some data that we don't always set great examples. 2 studies I'll just review very briefly here. In one study of residents, fewer than 50% of clinical teachers were identified as positive role models. And then in another, this was an innovative curriculum in Canada with problem-based learning. About half of the clerks and a third of the residents felt their teachers were not good role models in the physician-patient relationships. And these data, you could argue that they're a little older, but I think that some of these things may still be an issue. So moving on a little bit to role modeling as a skill, I'm going to talk about a little bit about when to use it, the educational theory behind it, go over the steps in more detail, and then we'll talk about the videos. So I want you to just think now about yourselves instead of your former teachers. So think of recent scenarios that you can recall the details of where you role modeled a behavior for a medical student, a resident, a fellow, anybody in your clinical setting. Just conjure up a scenario from your own experience. So what was the clinical context of when you were teaching, or what was the scenario? So one or 2 people want to share? Thank you.
Just yesterday, I had a resident come and present a patient who they were trying to get a history of chest pain from, and they said the patient is very not a good historian. That's the term we use. Often hear a lot from residents.
True.
And I'm like, well, how did you actually talk to the patient? And then we had some time, so I went into the room, and I just sat down. I introduced myself, and I said, I heard what your doctor has to say, but it's going to really help if you just tell me in your own words what happened. And then, the things that we all try to teach, I just let the patient talk without interrupting for a few minutes, and just made eye contact. And then when we came out of the room, I asked the resident how he felt about the information he got when we were both in the room together versus the information that he got earlier on. And I thought it was a positive experience.
Okay.
It seemed that way for the resident, but...
Okay, good. So I'm going to pick out, I don't know if everyone heard her or not. basically she had a patient presented by the resident. The patient was labeled as a bad historian. She went in to take a history from the patient with the resident and observing her, using silence, giving the patient space to talk, and then discussed it afterwards. Okay, good. Anybody else want to share? And I think history taking is a great opportunity to role model. That's something that's hard to learn in a textbook. Does anybody else want to share? Okay, that's okay. So I also want you to think about a little bit about how you went about the role modeling. Did you do anything to set up the encounter, talk about the encounter? What was your planning of the encounter? Or did it just sort of happen on the fly? So think about that for a minute. What were you trying to teach? What was your specific teaching goal or teaching point? Okay, I'm seeing, so everyone has a mental file pulled up, and then, yeah. Yeah.
Okay, so true, most of the time, at least for me, I don't really have a lot of time to plan out these modeling. It just happened very kind of
Right.
during the day, right? You go in, reset with the resident in the room, you say hi to the patient, bedside demonstration of clinical skills, you just kind of do that.
I agree. And I think sometimes there are really rich clinical encounters that you didn't anticipate being rich, and then it's like, oh, that was good. And so sort of, and I think a lot of us do that, and I think that's a lot of what I did and sometimes do when things are pressed for time. Yeah, so I think that that's a challenge. You mentioned a couple of barriers, which is just the time and the knowing what you're going to anticipate enough to plan it out and be explicit with your learner. Okay. So, and then we can talk a little more about barriers and challenges. So I think you mentioned one good time to use role modeling. I think it's really helpful with communication skills. So breaking bad news to a patient, addressing an emotional topic, speaking with a consultant, speaking with a family member, discussing something stressful or heated with a staff member, patient education about how to be health literacy friendly with patients. There are many different opportunities here. Anything regarding getting a history or a physical exam, either challenging parts or bread and butter parts, depending on where your learner is. And then teaching more intangible qualities like professionalism, ethics, and humanism. So now I'm going to back up just a little bit to talk, not a long time, but just a little bit about the educational theory of the behind role modeling. But before I do that, I'd like to just mention the 3 steps that I'm advocating when you can, not all the time, but priming, which is preparing the learner for the encounter, doing the encounter, which I'm not going to talk about because you guys already know how to do that, and then just debriefing or discussing the encounter afterwards. And I'll unpack those steps a little bit more in a minute. So this is a cognitive map about what's going on during role modeling. And if you start at the top, the learner is actively observing the role model, making the unconscious conscious, reflecting and abstracting, translating insights and principles into action, and then that leads to generalization and behavior change. Meanwhile, unconsciously incorporating the observed behaviors back into the next time that they see a role model. And then they're also exploring affect and value concepts. And so you can see that this is a mix of conscious and unconscious and explicit and implicit activities. And if we look at some of the things that we know that work in medical education and adult learning theory, so one of the things that role modeling taps into is the apprenticeship model, which is that learning occurs as changes to our schema or frameworks as we apply them to new situations and experiences, and then we test, revise, and reapply our understanding to those schema and frameworks to make them more sophisticated. It also taps into situated learning, which is where professionals learn from participating in and being absorbed into a practice environment. Learners initially start as peripheral to the encounter, and then as they become more skilled, they really become integral to the setting. And the model or the role model really shows learners how to be or behave in this setting. It also taps into observational learning, which I think is somewhat self-explanatory. And then the final thing I'd like to mention is just reflective practices. So this is when you review experiences to understand how knowledge, attitudes, and skills develop. And the role model can reflect on the experience, which facilitates the learner's reflection on the observation as well. And I think that, at least in my experience, this sometimes helps me too, because when I think about the encounter right after it happens, it's much more helpful for me to think forward about how I want to be better next time. So now if we go back to the steps, we're going to talk about priming, not so much about completing the encounter and debriefing. So frequently you may have a case like this, and you may opt to include the medical student. to take it to the next educational level, I think we can be explicit about priming the encounter before it goes on so that the student will have even more benefit. So this is, this used to be a 2-person show, and I made it a little more portable. So I'm just going to, let me read this down to you. So Miss Smith is a 63-year-old with COPD and lupus. She was admitted to the hospital with her 3rd pneumonia in 6 months. She had a concerning nodule and possible post-obstructive pneumonia on CT. Pulmonary performed a bronchoscopy with biopsies 3 days ago. The resident's off today, and the acting intern hangs up the team room phone and tells you that the pathologist called to report a biopsy showing adenocarcinoma. The AI asks what you want to do, so how do you proceed? So the female person in this encounter is the acting intern, and then you can pretend that you're David, the male attending, or you can watch David. So what I'd like you to do is just pay attention to what he does to prime the encounter, and then I'm going to ask you guys to comment on that afterwards. This is not perfect, but the point is that it's pretty brief and feasible, and it's low-hanging fruit to kick up the teaching a notch.
I just got off the phone with pathology, and they said Miss Smith's biopsy showed lung adenocarcinoma.
Well, okay. I'm glad we weren't here when they called.
Yeah, me too.
So how are you dealing with that information?
I'm not sure. I guess that's what we were expecting, but I'm still in shock. She and her daughter are going to be really upset.
Yeah, it is really hard.
Okay. So I think we should go tell her.
Yes, I agree. Before we go in there, let's discuss how we are going to approach it. So what are the goals of the discussion when we go tell her?
Well, we want to make sure she understands what she has, and we want to answer her questions.
Okay, great. You picked 2 of the most important aspects of breaking bad news. We need to make sure she hears the news, and we need to offer support. So how do you think we should start the conversation?
Well, I would like to go in there and see if it's a good time to talk. Then I think we should tell her that the biopsy showed adenocarcinoma.
I agree that we should check in to make sure she is free to talk at that time. If she is available, we should sit down and ask her what she understands about the disease.
Okay, I can do that.
Okay, sounds good. Once she explains her perspective, we should tell her that the biopsy showed cancer. It's important to use that word because most patients don't know what adenocarcinoma means.
Okay, I would like to tell her about the diagnosis too.
Okay, you can assess her understanding and tell her the diagnosis. And then I can take over with offering her support and seeing what other information she needs.
Okay, that sounds good.
Great. If you are uncomfortable at all while you are talking to her, just look at me and I can take over.
Okay, that's a good idea. That makes me feel more comfortable.
Okay, good. What questions do you have before we go in?
I don't have any. I think I'm ready.
Okay. So this is not a seminar on video production. If you know about one that you'd like to refer me to, please talk to me after the conference. But I think it makes it a little more fun because we role play all the time. At least I do. So okay, what did you notice? What did you notice that the teacher did in this encounter to prime the encounter?
Support.
Okay, support how?
Said, if you have any questions, let me know. You can look at me. If you have a problem, I can actually help you with. And then he also mentioned, Bill mentioned adenocarcinoma, said cancer. That's more meaningful. So supporting and teaching.
Okay, so making sure the learner didn't have any questions and they were ready to go, having a plan for intervention, which was the look at me if you need me thing, which is supportive for your learner, and then a teaching point about not using jargon. Not a seminar, not a lecture, right? But that was sort of the tweak of what that learner's plan was to make it a little more effective. Okay, anything else? Yeah, Rob.
The thing that surprised me that I liked was to check in with the student first. They had to see what she was doing.
Okay.
It wasn't really priming the encounter, but I think it was a really nice preparatory step before even talking about symptoms.
Right, so we care about our patients and we care about our learners, and so sort of attending to the learner emotion just a little bit to check in to make sure they could cognitively process this because we are human beings. And so I think that sort of sets an example of humanism and professionalism a little bit as well. which maybe wasn't as explicit, but modeled. Okay.
We also explicitly said that it's hard to do before, she said she was kind of taken aback, and he said, this is really hard.
Right.
And I think that might be helpful for students who've never done this before to recognize that it's hard for everybody.
Right, so some validation of the learner, supporting the learner. Anything else you notice? Aditi, yes?
You're attending out goals for the discussion right now. What the learner wanted to accomplish with the discussion, which I felt like probably made it less intimidating. This is what I'm doing, and this is how I'm doing it.
Okay, good. So setting a specific goal, which was somewhat learner-driven and learner-centered, right? So you got the sense that that was something the learner wanted to try and maybe felt a little, it was new to the learner, but something they were willing to try. So being pretty learner-directed there. Anything else? Yeah.
Hearing through the class how the learner will address the problem, will it be the first sentence, will it be the first question, and the first few things that the intern would say? And I think that's important to help them. I have a plan, I know what I'm going to say, and that's important. And then
Okay, good. So sort of making drawing out the arc for the learner with specific, here's what you should say, here's what I'm going to say, here's how it's going to go. So they could kind of know how to get things rolling. Okay.
I was going to play off a little bit on that. Two things. The first is that he actually made the learner say the words and then picked up, no, we don't want to say I'm a person. So actually, not just talking about what you're going to say, but how you're going to say it. And the other thing I like, what you were just pointing out, is the arc. So you're going to do these two parts, and then I'll close it, which is really helpful to the learner because they only have to do a little bit of it.
Right. And then they're also assessing the learner. When they ask the learner what they're going to say, then if the learner is perfect, they're done. They're not directing, they're not putting words into the learner's mouth unless it needs to be modified. Okay, good. So you guys are good. You picked up on most of the key tactics there. So I think in priming, you can ask the learner, or negotiate with the learner what the goals of the encounter will be. You can ask them if they want to conduct any of the conversation, some of it, part of it, none of it. You can share a small additional teaching tip, less being more in this scenario. This whole thing was, I think, 2 minutes. And then you can make a plan for intervention, right? So the signal of some kind if your learner needs help. So when we prime encounters, we're setting a mutually agreed upon learning goal that helps keep learners at their learning edge, which is where we want them, right? We don't want them doing stuff they're not prepared for that's going to be traumatic for the patient or the learner. And we don't want them doing stuff that's old hat and not exciting. So again, this is something in adult learning theory that's important. It's relevant. And it also helps them to create a framework or scaffolding and or refer to a pre-existing scaffolding. And then they can fit the new information from the encounter into that scaffolding and refine it for future use. So now,
Anna,
yes.
So another thing about that priming, I actually will also use it if I'm going, like if we're on walk-arounds or wards or we're going to talk to a patient, I will use it to set the stage for what I'm going to do. You know, like I'll say to the learner,
right.
My agenda in this is to tell them I'm taking them off 5 opiates, you know, or whatever, you know, so that they kind of, and this is how I'm going to do it. You know, so
right.
I do it to prime them to watch me have an encounter, not just to prime them to have an encounter.
I agree, and that's another good use of this skill, because you already have a strategy for how you're going to do something. So I'm going to go in, I'm going to validate their pain, I'm going to offer supportive statements, and I want you to watch how I transition the talk, or if there's a specific crux that you want them to focus on, because they might notice that 30 seconds before that, zone out for the important part, and then zone back in, right? I mean, it's hard for people to have 100%.
And it also, if I tell them, that you're going to get to this with the debrief, but if I tell them, I want you to watch and tell me what you saw me do, that's part of the priming too, right?
Right.
Because now you can't just be grateful that I'm having the conversation. You have to think about what I'm doing.
Right. So it keeps them engaged, it closes the educational loop, and it sets an expectation to kind of make them accountable. Good. Those are also good points. Any other questions about priming or thoughts? Okay. So now we're going to talk about debriefing. So imagine that you went around on Mr. Wilson and you encountered your new medical student at the bedside, first week of the clerkship, and you were observing the medical student's history of overnight complaints, which included new abdominal pain. You asked the medical student to observe your exam of the patient and then had him repeat it after you. Okay. So this is, in this scenario, the female person is the attending and the medical student is the male, which will be probably pretty obvious pretty soon. But
Okay, now that we are done with Mr. Wilson's abdominal exam, I would like to discuss it.
Okay.
What did you notice about how I examined him?
Well, you lifted his gown to examine the abdomen,
MMM, good.
and you listened before you percussed and palpated.
Okay, good. What else did I do to prepare for the exam?
Well, you put the head of his bed down and had him bend his knees.
Okay, good. And I also turned the light on.
Thank you very much.
Now, did you notice anything about where I palpated? He said he had pain in the epigastrium, so I started far away from the area of most pain so that I could get a more complete exam.
Oh, okay. Good to know.
And what did you find on his abdominal exam?
He had diffuse tenderness, worse in the epigastrium.
Good. I would also add that he had good bowel sounds. His abdomen was soft without guarding or rebound.
Oh, okay.
And what did I do when we were done with the exam?
Well, you covered the patient back up again and raised the head of his bed again.
Good. I also turned the lights back off and turned the TV back on. And I asked him if he needed anything. It's easy to forget to do those little things, but they are more considerate for the patient. Hopefully it shows him that I care about his comfort. It's hard to be in the hospital and have people coming in and out of the room all the time.
Yes, I guess I can see that. Thanks.
No problem. Any questions?
Should I have checked for shifting dullness on that patient?
No, you are correct in not doing that initially. That is only useful in patients who have ascites and he had a scaphoid abdomen.
so only useful in patients who have ascites and he had a scaphoid abdomen. Okay, so for those of us who are not in the world of liver disease, these guys can't pronounce everything. But okay, so what did you notice that the teacher did to debrief this abdominal exam? And this is pretty basic, right? Okay, yes, Amanda.
The teacher started by asking really open-ended questions. What did you notice? And
Okay.
then she shift to what did you notice in terms of how I compared? What did you notice during the exam? What did you notice when I closed the encounter? So started off broadly and let the learner talk, and then kind of went in on those smaller.
Good. And so you're sort of using the Socratic method, the what am I thinking, and then they give you something, and then there's more that you want, so you refine your question to get the more precise answer. And you may give them reminders or prompts about what you're thinking to sort of cue up the encounter. Good. What else did you guys notice?
I think asking in that way also makes him use his retrieval and his own thinking first before she adds something, rather than just her talking.
Okay. So using her own, it's sort of using the recall of the observation is a more rich learning experience and more likely to be recalled than just the attending sort of giving it to the learner. Okay, good. I hope I'm paraphrasing fairly. Okay.
He uses his own brain more.
Yeah. So he's doing more of the work. Okay. Anything else you noticed? Rebecca, yes.
Very explicit about the reasoning that she had behind covering up the patient. There was another lesson there.
And there was what with the
There's
last?
another lesson there for him about it's not just about the science, it's about the field.
Okay, so not just asking what, but asking why or explaining why behind what the student observes so that they understand where it's coming from, because they might not even notice that or not think about why that's important. Anything else? Okay. Is this something you guys commonly do, debriefing? Often? Okay, maybe more than the priming?
Yes.
Okay. So I think some questions you can ask, how did that go, just a general, or what did you notice? What went well, what was challenging? And then it's also a good time to confirm exam findings. What did you find on the abdominal exam? Because this is the only time they really get the right answer from you as the clinician. Did you notice anything that I did? And then being, like Amanda noted, more specific to properly position the patient, to make the patient more comfortable, to check the liver span. And then some of the other bigger underpinnings about, do you know why I did this? Do you know what I was concerned about when I did this? Okay, so not all, I think we debrief because not all students see and understand what is going on. They vary in what they understand and what they've been exposed to. And so debriefing is a time to clarify and correct any misperceptions and misunderstandings. And you take it not just from what went on to what did it mean, which again connects the experience with prior learning to result in a richer understanding. And as I mentioned before, I think it also can help us build our own skills about what we can do differently the next time. Okay. So now I'm just going to talk a little bit about next steps, and I think we'll have some time to talk about barriers if that's helpful for you, or challenges. So I think some of the things that we can do if we're not already doing them to improve our own role modeling are to be aware of it, that it's happening all the time, and to try to show a positive attitude. I also think that sometimes encounters don't go the way we want them to, like discontinuing opioids. Not always the cakewalk, right? You can have plan A, B, and C, and they can all kind of fly up in your face. And so I think sometimes it's helpful to talk about that and what you would have done differently to show the learners that we're not also learning and not perfect and have room for improvement. Similarly, we ideally are always setting a good example for our learners in terms of professionalism and humanism. I think that if something unintentional happens, that's also a time to call ourselves on our own shortcomings if we recognize them, which is not easy, but I think can be impactful for the learner. Demonstrate clinical competence, which I'm sure that everyone's doing in this room, and then priming and debriefing, making it a little more intentional. And like I said, anything is better than nothing, so you don't have to prime and debrief everything you do every day of the year. But if you think about it, just a little minute here and there can make it more meaningful for the learner. Be explicit about what you're modeling. And so I think those are sort of the main points. I think that locally we have a lot of institutional support for role modeling. We have protected time and support for teaching. There's an emphasis on the patient experience. It's something that we value. And there's also an emphasis on bedside communication skills. So I think from like an institutional culture that we have some positive things in our court. So now I'd like to talk a little bit about barriers. What are some of the barriers that you guys have noticed yourselves or could imagine would make this challenging? Time. That's a barrier to everything, right? Okay.
I have to say, I have a lot of trouble with being explicit about it.
Mm-hmm.
I do not. I have not found the words. I actually can't think of a physical exam encounter. Maybe when a student or a resident and I'm not comfortable running a family meeting or something very specific, have I said, watch how I do this. And I just don't know if that's, I think I do better debriefing when I do poorly, which is probably my own issue.
Because you're reflecting on it, right?
I'm reflecting. I have a lot of trouble saying, I do this really well, so watch me do this.
Yeah, okay.
But I know that I do it better than a third-year med student, but I still have trouble saying that. I don't know.
Okay, so I'm going to pick out a couple things you said. One is recognizing your own strengths. And I think that a lot of us have things that we do well, hopefully, and those are sort of automatic, right? This unconscious competence where we're just kind of in the zone and we're doing it and not really thinking about it. It's like a second nature because we didn't just learn it. And then when we falter, we have to be more conscious in our processing. And so we're going to be reflecting ourselves, so it's easier to reflect with the learner. And so and then the other piece, so recognizing your own skill sets and then being able to articulate it in like digestible chunks for the learner to absorb, kind of.
I cannot imagine sitting with the learner and saying, what did I do well there? Did you see when I did that? I just can't. But you
I don't think it's like a give me feedback. Yeah.
That's fair. But what I usually say is, what did you see me do? Right? Because that opens it up to good. And sometimes they say that after encounters that go badly, right? You know?
Right.
I was reflecting when you were talking on this. I had done one of these. I'm on the wards this month, and I had just done one where I said, okay, we're going to go in. And we're going to talk about transitioning this patient from IV dilaudid to orals today. Right? So I was priming. We went in. It went to hell. I completely kept her on the IV dilaudid. I came back out and I said, "What just happened?" And really, what I said was, "Why did I switch gears? Why did I make that decision other than?" It's just going to help,
But how would you have done that if it went well?
I said, what did you see me do? Okay. What words did I use? What words did I use?
And I also
I think I and me out of it contributes.
Okay.
But you know, in this particular moment, what did you guys notice? When I said blah, how did that go?
Okay.
Right. So I take the, you know, hey guys, I'm awesome, out of it.
it's more about your behaviors and not about you, so they don't feel like threatened to say like something positive or negative. Yeah, Julie.
I notice that I do what Missy and Reed are describing, what went well, how did that go? And this is usually family meetings for me. The resident usually says, well, that family was really reasonable, or you know, something like that. They say something about the family rather than about my skill. So
you were so lucky that was such a reasonable
so what I tend to do is, it helps to give people something to notice. So I make people write, and I say, write down one or two things that you see me do that are different than what you might have thought to do in that circumstance, and that surprised you.
Oh, that's a good
And then
one.
afterwards, I ask, what did you write down?
So did you guys hear what Julie said? Yeah, everybody here in the back. Okay. So writing down, I think that's a good exercise too. I thought about having folks do that during the encounters. And then having them write down something that's two things that are different than what they would have thought to do in that situation. And then they can talk about that, which is kind of nice because it also keeps them at their learning edge a little. Because, oh, that's new and cool. Let's talk about that. Okay.
So one of the things that I do when this comes up where the observer says, oh yeah, that was a great family, they were so easy, is I actually do what the second bobblehead did, which is that I ask about specific things that they may not have noticed about that I did intentionally that I want people to pay attention to. For instance, in a family meeting, I'm confident you sit down, right? No, I mean, it's stupid, right? You do it intentionally in every single family meeting, and that's something that facilitates you getting to a good family meeting. You probably talk 30% of the time and you let them talk more, right? And so I'll actually make it explicit. Did you notice how much of the conversation I talked about versus how much of the conversation they talked about? And I'll draw out specific things, just like the second bobblehead said. Did you notice how I pulled the patient's covers back up? Did you notice how I put the head of the bed back up? Did you notice this? So that I'm reinforcing these are the things that I do that are intentional, that I want you to walk away knowing that's important.
Right, and it's not did you notice, it's not a value judgment on you, it's just a did you notice this behavior which led to this, which I was hoping would lead to this outcome. Okay, so sort of, if they give it to you, it's easy, right? If they recognize all the stuff you did, then you're done because they got it, you can share a teaching point. But if you have to drag it out of them, that might be a good strategy.
And then you can even follow that up with, do you think that's one of the reasons why this family meeting went so smoothly? Do you think it's just I was lucky? Or is it, do you think that that really helped this family to come to some closure or come to a decision and that kind of stuff?
Okay, good. Yeah, and so then tying that behavior back into the result and the initial impression or assessment from the learner, oh, it was an easy family.
But it's like the open-ended questions followed by closed-ended.
Right.
What did you notice? What did you see me do?
Right.
How much time did I talk, right? I mean, so you can do the big questions and then to the narrow questions to make, if they don't name the skill you're trying to get at, to name it. But that has been a growth process for me to have in my head what I did, right? You know, I mean, it's like when you're in those encounters, it wasn't natural for me to begin debriefing because I actually had to think about my own algorithm and what I do. You get old and you get good at some things and bad at some things, you know, but you don't really know why you do it. So I actually had to put a fair amount of time and energy into pulling out the explicit skills I wanted them to take away.
Right, because you're parallel processing, because you're doing it and thinking through it in real time, and then you're also recalling what it was specifically that you did and what it led to. Yeah, I would echo that when I started doing this, it's a skill, so the more you practice it, the more refined it becomes. Jason, sorry.
So we've been talking a lot about the intentional and explicit things that we do, but one thing that I struggle with is the unintentional role modeling. I feel like there's so much that learners are watching me, and there's so much that I do that I'm not even conscious of. And I worry, are they getting the wrong idea?
Role modeling.
Yes.
It's like implicit bias.
Yeah, that's right. So, you know, I don't know what to do, like how I talk to other professionals, how I interact with the EMR. There's so many things that they could be learning. Is there a way to make it more explicit or to help identify what the learner is taking away from that unintentional stuff?
Yeah, I think at the end of the month it would be hard, or the end of the week with a learner it would be hard. I think that in the moment, if you recognize something that goes well or doesn't go well, or you were exemplary or not exemplary, and you think that to yourself, to mention it. I mean, I also think that learners have exposure to a lot of different role models, and so there are certain things that some of us are stronger at than others, and hopefully they take the cream of the crop from everybody. But yeah, I think that's tough because you can't always be aware of what you're doing every minute of the day. I don't know if others have a strategy for how they manage that. Yeah, Mike.
Yeah, but Jason made a good point. If you read the role modeling literature, like the camera's on all the time.
Yeah.
And that's that the stuff when you go, geez,
Right.
They catch that, and so you got it. You're on stage the whole time. You got to be careful. These sort of big and small events that we model, they deliver the bad news as a big event, and then go on to do what Don was saying, it's a small daily event. Those are kind of snippets out of the bigger photographs out of the movie,
Right.
You got to remember that the movie's playing the whole time. And when they ask students, like in qualitative kind of studies afterwards, they bring up all these other things.
Yeah.
I think one thing, Jason, that I try to do is when I react to a situation and then I think about it later and I was a jerk there. Then I go back and I try to be clear with it. Say, yesterday when this happened, I had a very strong visceral reaction, and I want to apologize to you guys that as well. Let's talk about it. And so I think you're going to have those moments where you're not the best Jason Rose. When you have that moment to reflect on it and go back and undoes a little bit.
And it shows humility, right? And I think
So you role modeling something different.
Right.
Right? That's a positive.
And so if you recognize it, it's an opportunity. I mean, I think even if you recognize it the next day, you say, oh man, I was sort of frustrated with that phone call or whatever. I think it's okay to call yourself on that to the learner as much as you feel comfortable. Yeah. One more comment, or two more comments.
That I have to struggle with personally is how I feel about the learner.
Okay.
So if I feel that this is someone who's more open, and this is more for the debriefing part of it than the actual interaction with the patient or modeling that. So I have to be careful that I don't let my personal preconceived notions about a learner's ability play into that. So that's something that I think I still have to be more mindful of, that I treat the learner with the same respect that I would all of them. So if I feel that someone is not as open to what I have to say and is really not interested in what I'm trying to do over here, I might communicate with them differently. And that may actually backfire and make it a negative experience for both of us.
Okay, so I don't know if everyone heard that, but sort of your personal feelings about the learner and how open they are to receive your teaching. And I think I struggle with that in various settings and scenarios, even outside of role modeling, and I think that's a tough one. And you feel like if you're biased against the learner because they don't seem engaged, then they have a more negative.
To come out in the way I'm communicating.
Right.
So I'm trying to do something. I'm not trying to, make something that I think exists even more pronounced.
Right. Right. So, and I think the first step of that probably is being aware of it. And if you're a little bit conscious of it, that might make you more able to override it in a helpful way. If you sort of check in with yourself about the learner and then you don't translate that into how you treat the learner, I guess.
So it's not so much treatment, just nuances of communication.
Uh-huh.
And I noticed this in myself when I'm addressing someone in a slightly different way than I might address another learner, and I have to be careful of that.
Mm-hmm. Mm-hmm. Okay. And then Allie, I'll take one more comment.
Yeah, this was just thinking about that I actually do set the expectation that I want my learners to be observing each other, but I don't check in with them at the end. So when I brief them and orient particularly students for a rotation, I will say, your job is to be a sponge. Not everything will be spooned to you. Part of your learning on this rotation is to observe what the other folks on the team do, how do they do it, but I realized that I never actually check back and
close the loop.
I never close the loop, honestly.
So sort of third person role modeling, like pay attention to your resident. He's great at this, but you don't follow up with them.
Yeah.
Missy, you were
So,
going.
yeah, I was just going to say, I have become more explicit with that just recently about if I see somebody do something well, naming it when we come afterwards. Did you see Nick sat to talk to that patient? Did you see what? So it's sometimes that's easier to. That's a twofer, right? Because it's a positive reinforcement for the learner who did it, and then it's a learning moment for everyone else. And it's always easier to compliment other people, perhaps, than yourself. Right? So,
And then your brain's only doing one thing. It's only watching. It's not doing anything, remembering. Okay, good. All right, so those are helpful tips from the group. Hopefully, if any of those are challenges that you have been struggling, you can take them back and try them out. I think those were most of the things that I also identified. So just like a few parting thoughts. Role modeling is happening all the time. The video is on, the camera is on for 4 years or 3 years of residency, intentionally and unintentionally. Be aware of the example that you set for the learners whenever they're with you, and then be intentional about making role modeling a skill to make sure your learner gets your teaching points. So you're meeting them at their learning edge, you're building on existing knowledge, you're making sure teaching points are clarified, and it allows you to continue to improve on your own actions. So we must acknowledge that the most important, indeed the only thing we have to offer our students is ourselves. Everything else they can read in a book. And so I'd like to thank Dr. McNeil and the rest of the Academy for the invitation to speak today. And then Dr. Spagnoletti actually helped me come up with these scenarios and debrief them with the interns. And Dr. Corbelli used to act them out with me before I found NOMAL. So, okay, thanks for your time. What questions can I answer for you guys?